Welcome to the podcast. I'm Jess, a family nurse practitioner and legal nurse consultant, and this is the space where healthcare, law, and real-life situations intersect. Each episode is designed to break down complex medical and legal topics in a way that's clear, accurate, and grounded in evidence, without fear, misinformation, or sensationalism. Whether you are a healthcare professional, attorney, gig worker, parent, or simply someone who wants better understanding of how medical events and legal responsibility overlap, you're in the right place. Let's get started. Imagine you get a call from your clinic. Your test came back positive. Your heart races. Do you need treatment? Is it a false alarm? Or is it urgent? A few weeks later, a friend told you their scan showed a nodule, and the whole family panicked, but the doctor said it was likely nothing. We all have stories like this: confusing numbers, scary wording, and not enough context. Today, we fix that.
Here's the promise for the next 20 minutes. I'll give you simple definitions for the technical terms you see on results, real-world examples you can recognize, and short scripts you can use when you call your clinician, so you leave the conversation with meaning, not confusion. No math quizzes, just practical thinking you can use today.
Section 1. The basic tools: sensitivity, specificity, false positives, and false negatives. Think of a test like a fishing net. Sensitivity is how fine the net is at catching every fish of a certain type. A very sensitive test catches almost everyone who has the condition. So if the test is negative, we can be fairly confident you don't have it. That's the classic one-liner. Sensitive test, when negative, rules out. Specificity is the opposite. It's how picky the net is at only catching the fish we care about. A very specific test rarely flags people who don't have the condition. So when a specific test is positive, we can be more confident it's real. One-line refresher: specific test, when positive, rules in. False positives and false negatives are just the mistakes the nets make. A false positive is when the test says you have something you don't. A false negative is when the test misses something you do have. No test is perfect. Understanding which mistakes are more likely helps us decide what to do next. Section 2. Why who you are and how likely you were to have the condition before testing changes everything. This is the idea behind pre-test probability and Bayes thinking. If someone with recent exposure and symptoms gets a positive test, that result means more than the same positive test in someone with no exposure and no symptoms. Put simply, test results don't float in isolation. They land on your personal likelihood. Quick mental checks. Ask yourself, was I symptomatic or exposed? Does the test match what we were looking for? How common is the condition in my community right now? Those 3 quick checks dramatically change what a positive or negative result suggests.
Now, let's walk through real examples. Example 1. A basic metabolic panel, or CBC, that flags an abnormal value. Labs list reference ranges derived from populations, not necessarily you. A mild, isolated abnormality in one value often needs context. Are you on a medication? Are you dehydrated? Is this a small, likely harmless variation or part of a trend? Trend is the key word. A single mildly abnormal number often means recheck or watch, not alarm.
Example 2. PCR versus antigen testing for infections. PCR is very sensitive. It can detect tiny amounts of genetic material. That makes it excellent at catching infection early, but sometimes PCR detects remnants after you're no longer infectious. Antigen tests are less sensitive, but often better at indicating current infectiousness. So a positive PCR might need clinical context before we act. A positive antigen in a symptomatic person is a stronger signal for current infection. So a positive PCR might need clinical context before we act. A positive antigen in a symptomatic person is a stronger signal for current infection. Example 3. An incidental imaging finding, the incidentaloma. You go in for abdominal imaging after a minor injury, and the radiologist mentions a small liver lesion. Most incidental findings are benign, but wording matters. Words like suspicious for malignancy are different from small, likely benign, recommend interval follow-up. Ask for the exact language in your report and whether immediate action is required or if watchful waiting is appropriate.
Section 3. Communicating results and avoiding common pitfalls. First, exact scripts to bring to your clinician. Use short, specific prompts. Can you explain what this result means for me personally, given my symptoms and history? Or, is this an urgent issue, or can we recheck this in X weeks? Why? For test-specific clarity, try, is this test more likely to miss the condition or to give a false alarm? How does my risk change the meaning of this result?
How to request context in your chart. Ask the clinician to add reasoning in the note. Please document why we ordered this test and what threshold would change management. That helps future providers and protects you from unnecessary follow-up. When to seek a second opinion. If recommended invasive procedures or major treatments hinge on a marginal or unexpected test result, pause and get another read or repeat the test.
Common pitfalls to watch for. Over-testing creates more false positives and anxiety. Ignoring symptoms because a single test is normal can create false reassurance. And headlines that trumpet test accuracy without mentioning the population tested or pre-test probability. A lab result out of range isn't always bad news, and a normal result doesn't always guarantee safety. Context is everything.
Recap and takeaways. Takeaway 1. Always ask about pre-test probability. Were you symptomatic or exposed? That changes what results mean. Takeaway 2. Know whether the test is designed to rule out high sensitivity or rule in high specificity, and ask how that affects the recommended next step. Takeaway 3. Use the scripts I gave. Ask for personal meaning, urgency, and whether a repeat or second opinion is appropriate. Those 3 moves will save you worry and unnecessary interventions.
A quick bonus. A simple script for urgent versus non-urgent. If this test means I might need immediate treatment, please tell me exactly what signs should prompt me to call 911 or come to the ER. If not, when should I follow up and with whom? Clear thresholds cut through anxiety and clarify next steps.
Before we close, a brief safety note. These explanations are educational and meant to help conversations with your clinician, not replace medical evaluation. If you're experiencing concerning symptoms, chest pain, shortness of breath, severe bleeding, sudden weakness or blindness, seek emergency care immediately. CTA time. If this episode helped you feel more confident reading results, please subscribe to the podcast so future episodes reach people who need clear medical explanations. Share this episode with a friend who's been confused by a test result. If you have a question you'd like me to cover in a future episode, send it to the show. I often build episodes around listener questions.
Thank you for listening. If today's episode helped clarify a medical or legal issue, or made you think differently about how emergencies and accountability intersect, that's exactly why this podcast exists. I'm Jess, a family nurse practitioner and legal nurse consultant, and I work with attorneys, organizations, and professionals who need clear medical insight in complex cases. You can learn more or schedule a consultation at faqbynursejessconsulting.com. If you found this episode valuable, please share it, subscribe, and leave a review. It helps this education reach the people who need it most. Until next time, stay informed, stay compassionate, and always put safety first.